Why don't we go ahead and get started, and others no doubt will join us as we go. So what I want to talk about today is closing cases and settlements. We've talked before about how that happens with patients being MMI, PNS, and we send in the PR4, or at least the information to RateFast or Dr. Kujak, and then the patient is the PR4 is generated and the claim settled. And most of the time that proceeds smoothly, non-controversially, and whatever the outcome of the settlement is what it is. But occasionally we have some challenges with the patient circumstances, some of which I'd like to talk about today. And then they come back to rest with us in some of these situations. And the question is how to handle some of these that we'll talk about. And I've got a couple of examples here of cases where the conclusion was a little different than usual. And sometimes we have to think through what we're going to do at that point. So here's one with closing a case, settlement, and we'll just talk about what happened and how to approach some of these situations. So what we're going to be considering is the fact that there are different conclusions to some of these cases. They don't always end in tidy fashion with the processes that we've discussed before. So I want to talk about that, the nature of settlement options, how the carrier goes about settling. And I think it's worthwhile for us to be familiar with this because as providers, there's a place for us to work with or discuss with patients what to expect from a claim standpoint when the case is over. We're not attorneys, we're not intending to be, we're not adjusters. That's not our role, but we're providers, and future medical care can be an issue for some of these patients. And there's some settlement options that I think the patient would benefit or does benefit in understanding before they're ready to settle with the carrier. And even if an attorney's involved, I think the patient really ought to understand these things. And there's a place for us to provide them some insight into that. And then further care after settlement, what happens there? Most of the time we're not involved, but sometimes we are. And so I want to talk about what our role may be in some of these situations. So key points: provider control and case conclusions can vary. Carrier calculation, how do they calculate the carrier's office? They offer negotiating a settlement, future care, and our role, and then assisting the abandoned patient, which I'm meaning generally is abandoned elsewhere, not by us. So here's the patient. Patients at Carpenter, we saw in one of the clinics in July of 2 years ago, 2021, was lifting heavy machine, installing the 12-foot fiberglass panel or panels on the wall. He's wearing wet gloves, working at night. One of the panels apparently slipped. He attempted to catch the fiberglass panel, causing a pull in his left shoulder. There was immediate pain, and described it was rated as 7 out of 10. Seen on the 2nd. And then on the 7th, 5 days later, pain was intermittent, maybe slightly better, but not substantially. Been working limited duty, still at night. Cold temperatures caused pain to increase. X-ray of the shoulder showed a 1st-degree AC separation. So the plan at this point was physical therapy, see the patient in 2 weeks, and then do whatever needed to be done. Well, interestingly, patient didn't come back, actually never came back, but in late September of last year, we received a fax to the clinic with the settlement of the patient. And so much had happened, obviously, in between when the last visit occurred in mid-2021 and then 14 months later. And so what I want to talk about in this case then is, and this sometimes happens, particularly when attorneys get involved, the patient not infrequently is sent to a provider with whom the attorney is familiar and with whom the attorney works in a sense of referral. And the attorney can make that change. It's a matter of contacting the carrier and indicating that the patient wants to change the primary treating physician, and So it's possible to have that happen without our involvement in the decision, and in most cases without our knowledge. And so the patient may go to a pain management clinic, that's not uncommon, may go to some provider in the community, again, with whom the attorney has not a relationship, but makes referrals. It can be a variety of folks, maybe a primary doc, maybe a specialist. But in any event, the patient's gone. And most of the time, we don't ever find that out unless the patient, for some reason, comes back to us. We don't know that that's happened. We know that they've departed, but we don't know what the circumstances are. Occasionally, we'll get a document from somebody indicating that this has happened and information about the settlement. The other time we'll occasionally get information is we may get a copy of the PR4, but that's primarily if the provider who did the PR4, the permanent impairment evaluation, not us, not Dr. Kujak, wherever the attorney sent the patient, has recommended some additional treatment and opined that the patient's really not MMI. So then, because we may well be yet named still the PTP, then it comes to us to implement the recommendations from the provider who had done the exam. And in that case, it's actually, if it's not a PR4, it's generally a QME, and the patient then is recommendations are made by whoever this provider is. So they may come back to us. Otherwise, we often don't hear about it. But when we do, and we get documents like this, in the case of a closure of a case, I just want to touch bases on what this situation was with this patient. Now, we don't know what the residuals were at the time of the rating, but it was determined to have a value of $55,000, total value to the patient in the form of a settlement. And that was an offer made by the carrier based upon something. And of course, what happens in these cases, excuse me, if the patient's determined by, in this case, whomever other provider, that the patient's PNS, and rated the patient, then the carrier will take the whole person impairment and other pieces of information, age, the job, and wage replacement issues, and calculate a dollar amount. And that can, from there, go up or down depending upon the attorney and the carrier in a settlement. In this case, the offer was for $55,000. And this is the verbiage that comes with it: $55,000 in addition to all sums which may have been paid previously. Excuse me. And what they mean there is everything they've paid in wage replacement and medical. So the patient, the benefit theoretically of the patient is the $55,000 that's the offer, plus the fact that these other expenses have been paid, except permanent disability advances. And what happens here is, after 104 weeks in the aggregate, meaning that if a patient's off work and getting temporary total disability benefits for a total of 104 weeks, which don't need to be consecutive, but just in the aggregate, then no more disability is paid. And we've had some patients where they've been off work for 2 years, 104 weeks, and the payments stop. Now, in some of those cases, the carrier recognizes that there's going to be permanent disability payment. They may have an estimate of what they think that's going to be even early on. And then they'll start advancing permanent disability payments to the patient. It's the same amount typically as they were getting when they were off work. And many times the patients don't know that these are advances on their PD settlement. So if this was a patient, this patient didn't reach 104 weeks, so that wouldn't be an issue. But if it were a patient that had exceeded that and been maybe another 30 weeks before the claim was settled, then those payments during that time are going to be deducted from the, in this case, $55,000. So patients don't understand that oftentimes, and it doesn't really influence anything that we would do, but sometimes they can be surprised with learning that later. In any event, 55,000 except PD advances, none here. And then this goes to the judge, Workers' Compensation Appeals Board. The judge concurs with this, and then the settlement's made. And then it gives some more information in a subsequent paragraph. The award is made in favor of above named applicant, payable as follows: in the sum of $55,000, less PD advances, done here, less the attorney's fee, which typically is somewhere, the average is around 12.5%, may go up to 15%, but it's the value of the claim. So it's 15% of the 55,000 that's going to be the settlement. So the 55,000 is reduced by 8250, and then the balance, the payment. And then it says also liens are to be paid and or adjusted, set forth by the CNR agreement. You recall that CNR, compromise and release, is where the patient receives the amount of money that's negotiated or offered, and there's no future benefit to the patient. There's no future medical care. If the case is settled by a stipulated advance or a decision, then there's provision for something which is normally future medical care. And that $55,000 is going to be less than, because the carrier is trying to calculate what the likelihood of future costs will be. So in this case, it's a CNR, 55,000 minus 82, and then liens are to be paid and or adjusted. And sometimes in litigated cases, the attorney is requesting care by a chiropractor or somebody else, and they're not authorized. But what'll happen is that care will go ahead on an unauthorized basis. Then at the conclusion, that provider, the chiropractor or whoever it happened to be, will submit a lien against the claim, the case, and may be paid or may not be paid. It depends upon what's negotiated. So the point of this is the patient's $55,000 is reduced by the attorney fees, by any liens that may occur, and if there are any disability, PD advances, again, not in this case. The point of this is, excuse me, that the patient doesn't, they may see the $55,000 figure and get a lesser check. And by the time the expenses are taken out, whatever the settlement negotiated sum is, may well be reduced substantially. And that's intended to be what's present for the patient to cover future medical care as they may need. And it may not be much there. So it's worth, I think, I don't know, Dr. Pricey, you may choose to weigh in on this or not, but I think it's worth telling a patient the difference between a CNR and a stipulation, because the attorneys typically are going to want to get a CNR because the settlement sum is greater, and the carrier is going to want to get a CNR because they get out from underneath the claim. But that may not be the best thing for the patient. So I often have a discussion, if I can see this coming, just explain to them the difference between a CNR and future medical care. And then I usually say to them, I have no opinion on this. This is something for you to decide, but you need to understand what a CNR is and what a stipulation is. And then they've got at least that piece of information before they sit down with their attorney to work out whatever the settlement is. So I don't know, Scott, do you see it any differently than that, or do you have a sense of that?
No, Steve, I say the exact same thing you do. I try to stay kind of out of the details of it, but let them understand or make them understand that um, there's an advantage to the other side, other parties involved to a big lump sum payment,
All right.
and that it's very, very tempting to take a big lump sum, but it may not be in their best interest.
Yeah, and I usually offer the proviso, I'm not an attorney, I'm not an adjuster, I'm not here to give you non-medical advice, but this has implications for care. So in any event, I just tell them that. And there are a lot of patients that are very appreciative, because most of those I see have not been through this process before. They don't have a clue what's going on, other than the fact that they want to be better. We, of course, get some patients that you could go over this with them and they just aren't going to understand it. But nevertheless, make your best judgment about it. And if any of you have any questions later more about this, want to talk about it, I'm more than happy to do that. So,
Steve, just to add one more thing on there, I think that attorneys tend to either really openly or subtly steer these patients toward a lump sum outcome, because it really is in the best interest of the attorney to do this too. So,
yes,
yep,
I agree completely with that. So just a short refresher on what gets us to this point, case closure. If it looks like there's no improvement in the next 12 months, so we've stepped back a little bit in the chronology of this, no likely improvement in the next 12 months, and every reasonable diagnostic or therapeutic maneuver has been offered to the patient, which may or may not have been accepted either by the patient or the carrier. There's really nothing more to do. This is often a gut level decision. None of us can predict really what's going to be going forward in the future, but the labor code advises us when it looks like nothing's likely to change in the next 12 months, then it's time to consider somebody maximally medically improved. That's the medical term. They're as good as they're going to get in the foreseeable future. And the administrative or claim management term is permanent and stationary, which are the magic words for the adjuster. And then the permanent impairment evaluation's done, PR4 submitted, as you know. And important to include, and we have this in Epic, when you're ready to send information to RateFast for their inclusion in the PR4, be sure they'll do the apportionment for us, which means how much of the disability left over is a result of this injury and how much of it is a result of any pre-existing condition. We don't need to worry about making, in fact, you shouldn't make any statement about 40% due to the first injury or 10% or some number. Just indicate what the prior condition of the patient relative to this injury was before they came to see you. So they had a prior low back injury, they had surgery or not, they had some amount of residual pain or not. Try and just be descriptive, and that will assist RateFast in making a decision about apportionment for the claim, of the disability of the claim. Permanent work status with restrictions, you really need to make your recommendations there. That's a hard thing for RateFast to do. We need to state it. And then any future medical care, be sure and put that down. And there's some check boxes in Epic where you indicate what you think, what sources of care and what care might be needed. Put that down, and that's helpful in terms of completing the PR4. And then the calculation, as I mentioned, that produces a whole person impairment, and then the adjuster will take that information and add their own modifications based upon categories mentioned and come up with a figure. And so we talked about CNR stipulated decision and allocation of the settlement funds. There's a situation, and I'm interested in anybody's comment about this. What happens to the patient then after the claim is resolved? There's future medical care or not, but the patient comes back to us for care if they've got an ongoing problem. And when these claims settle, of course, they settle with a dollar value and they've got future medical or not, but they're settled because there's a residual problem. There's residual symptoms and findings, and there's more often than not some form of disability. So from the patient standpoint, the problem hasn't gone away. And what happens when they come back to us? There are two categories of care that we should continue to provide. One is if we've recommended future medical care, we continue to be the PTP, the primary treating physician. So it's our responsibility, really, unless we abdicate that, pass it off somewhere else, to continue for providing medication or whatever it is they're going to need. But typically we don't schedule appointments for these things. We say, The implication is, or we tell them if they come back that first time, come back as provided in your settlement, the stipulation, and we can provide care, but you don't generally schedule visits on a regular basis, just there to provide whatever was provided in the settlement. And you need to get a copy of that PR4 so you know what the settlement was, or at least the recommendations. If we've done the PR4, then we have it. RateFast has provided it to us. If, on the other hand, it was done elsewhere, there was the claim was settled, as in this one, on the basis of another physician's examination, then we need to get a copy of that to see what's provided for. And we don't want to start working up the patient again. We just need to provide care for whatever the settlement included. So need to get a copy of that. The other case, however, where we may provide regular care is in those situations where there's the high blood pressure that's considered part of the case as an adverse consequence, compensatory consequence, or in some cases, strangely enough, diabetes is developed or obesity is developed as a consequence of the case. Then those folks we do need to talk to regularly and provide the medication. But otherwise, generally don't schedule visits. Let them come back when they need something, and then you provide it consistent with whatever the agreement was. The other situation we sometimes see is care has been transferred by the attorney to another provider who's then been providing care and may well have done the PR4, but not infrequently, when all's said and done, that provider abandons the patient and says effectively that they're on their own, and the patient may well come back to us for care. Or there'll even be, on occasion, patients that we've never seen before have gone through a claim process, had a settlement or a CNR. Well, they've had a settlement either with stipulation or CNR, and come in expecting care. And what will occasionally happen is they'll come in under Medicare. They may have the Alliance, or they may come in, Medicare, or they may come into Medi-Cal. They may have the Alliance. So we may have to deal with that. How do we do that? What should we be doing? My opinion, and others may see it differently, is if there's somebody that comes in that needs care, we've got, I think, a responsibility to at least assess the situation. But if we're going to pick up care for that person, and particularly if it's an Alliance patient and we're the provider, and all this has happened with other providers, what do? Well, we end up needing to treat them. But in this case too, I would really try and get a copy of the PR4, find out what the basis of the settlement was, and then I would just provide care based upon what that PR4 showed, and not go through the business of starting all over to work up the patient, even though in some cases that's what they want. I would just make every attempt to pick up from where the other provider left off. Presumably they've had all reasonable care offered to them and provided if it's been authorized. And I would just try and go from there. Don't start the MRIs again unless there's been a material change in the patient. So that's the way I go about it. You'll do whatever you think is comfortable to you. And we see these things and these come in. So sooner or later, you're going to have to confront this, and you have to decide what you think the reasonable thing is for a case like this. Anybody have a different opinion about that? Seen those patients? Okay. So the guidance is, in general, then, we go through the process with work comp claims. Most are going to settle. They're going to conclude. There's no problem, but occasionally these unusual situations will arise, and then we just need to think through what the best answer is, trying to reasonably meet the patient's needs, but not being duplicative of things that have gone on before. All right, let me just take a quick look at one other patient. I'm going to stop the recording for a sec here.